And we're going to have my friend and colleague, Dr. Ackerman, up in just a moment. But let's go through a couple of whet your appetite questions on this topic. So the first one is, look at those three leads and say the most commonly identified genotype that causes this ECG is a gain of function calcium channel defect, a loss of function sodium channel defect, a defective sodium, calcium, and potassium channel beta subunit, or loss of function potassium channel defects. Looking at this ECG, which long QT subtype is this? Is it type 1, type 2, type 3, type 7, or you don't have a clue? In this one, your patient has this disease and is pregnant. What is the likelihood that her fetus will be affected by the disease? 25, 50, 75, don't know. Here we go. Excellent. So, come on up, Mike. So Dr. Michael Ackerman is my friend and colleague. He and I started medical school together just a few years ago. He is now a world expert in sudden cardiac death genomics, the cardiac channelopathies. He's a professor of pediatric cardiology, adult cardiology, pharmacology. I don't know how many other, he's got some long name professorship. But anyhow, he gives one of the best lectures on cardiac genomics and long QT sudden death syndrome. So Mike, thanks for being back again this year.
Great seeing you. Well, good morning and congratulations. I think this lecture marks the halfway point of your board review course, and I'm delighted to bring you towards lunch. And so I want to thank Drs. Amon and Ishimura again for the invitation and congratulate them on just really, truly the best board review course in world from my vantage point. So welcome aboard. These are my conflicts of interest. I don't think they affect my ability or our ability together to try to do a good job with these learning objectives. We're going to go through these 3 times in 3 iterations for 3 of the important channelopathies. And we'll start with Brugada syndrome. And many of the board's relevant questions are derived from this latest consensus expert statement regarding management of patients with primary arrhythmia syndromes. This is an amazing collection of diseases. It's really a new, or not that new any longer, subspecialty within the heart rhythm services. And long QT syndrome is the most common, and that's where we'll conclude, but it's not alone. And we could really go over any or all of these and even start thinking about cardiomyopathies emanating from primary defects in the ion channels of the heart. But we'll focus in a board's relevant fashion to the 3 major channelopathies, and we'll do the learning objectives starting with Brugada syndrome. So help me out with this patient or this patient's electrocardiogram. Your patient has this electrocardiogram. He's 27, and he gives this ECG to you spontaneously, and he just fainted in the hot shower. You'll recommend a prophylactic ICD, yes or no? Just want to get a sense, who are the yeses in the room and who are the nos? Those who would give him an ICD, raise your hand. Those who would not, raise your hand. So he will either get an ICD depending on whether we're Republicans or Democrats. No. It's about a 50-50 split, isn't it? And here the correct answer is he should absolutely get an ICD if you and I did not like the faint, if we envisioned an arrhythmia precipitating the faint. On the other hand, if we concluded that he was in normal sinus rhythm and had a vasovagal mediated faint in the hot shower, we would then stand down because there would be no indication for ICD monotherapy. So the story is critical to the faint. Brugada syndrome, as is shown here, starts with this ECG, but as we'll come to quickly, ends with this ECG, at least for answering the board's question. Brugada syndrome with this ECG and a faint we don't like is Brugada syndrome, is symptomatic Brugada syndrome, is ICD-worthy Brugada syndrome. This is the ECG that matters. So the type 1 cove-shaped ECG with 2 millimeters of ST segment elevation in either V1, V2, or V3. with the leads in any intercostal rib space. So whether standard placement or higher lead location, when that pattern emerges, that equals Brugada syndrome for the boards. Now, if it's non-diagnostic, that is a saddleback type 2 or a wimpier one type 3, that is irrelevant unless it converts to the type 1 pattern when we move the leads up the chest or when we give a sodium drug challenge with agmaline, flecainide, or procainamide. What we mean by the high lead location is simply taking the precordial leads V1, V2, V3, repeating the ECG after moving it up one space, then repeating the ECG again after moving it up closer to the head a second space. And it doesn't matter which space it emerges in, because all we're really doing is anatomically localizing where the right ventricular outflow tract is. So there's no difference for the patient in terms of risk as to which space the pattern emerged. So to sum up for Brugada syndrome, this ECG, type 1 and a faint we don't like or a death attempt which we don't like, that's symptomatic Brugada syndrome. This ECG in your patient and in another one of his or her relatives, that is Brugada syndrome. This ECG and a positive genetic test, that is Brugada syndrome. And by itself, according to the 2013 guidelines, is equivalent to the diagnosis of Brugada syndrome. Most disagree with this, that this was an over-indictment of equalizing an ECG finding to that of a sudden death syndrome, but that has not been reversed yet. In terms of the pathogenic basis, Dr. Amon said you got 95% right with that question already, but for the boards, for the subset of Brugada syndrome that's genetically findable, the correct answer is loss of function mutations in the voltage-gated sodium channel. But that correct answer is going to turn out to be only true about 20 to 25% of the time. And even though there's 23 Brugada genes that have been discovered, we still don't know over 2/3 of Brugada syndrome. The second most relevant Brugada gene is the gene that encodes the L-type calcium channel. And there's some nuances that are emerging clinically in how you and I can predict whether it might be the sodium channel version of Brugada syndrome, which is the most common of the 23 genetic versions. And that is if they have the Brugada pattern and a prolonged PR interval, evidence of conduction disease, then that is about a 40% likelihood that that Brugada patient is sodium channel mediated Brugada. So for the boards, the subtype of Brugada syndrome that is genetically findable, the most common reason is sodium channel loss of function. Now, who should get a defibrillator? Aborted cardiac arrest, class 1 indication, fainting that you and I assess to have been arrhythmic. By story, by monitoring, by capture, whatever our assessment was, that's a class 2 indication for an ICD. And then we still remain vexed, and so it won't be addressed on the boards. What do you do for the asymptomatic Brugada patient for his or her risk stratification? Should you do an EP study? That really is not fair to be on the boards because it's very contentious, remains very debatable, and the suggestion has been based upon the literature that risk stratification by an EP study probably doesn't make sense, although the latest from a meta-analysis last year would suggest that if you do a less aggressive EP study, and if we induce VT or VF with a double stimulation protocol, that portends about a 1.5% chance per year. And if that study is negative, about a 0.5% chance per year. So those numbers are interesting because a positive EP study doesn't even rise to the threshold for when Dr. Amon would implant a defibrillator in a patient with hypertrophic cardiomyopathy risk factors, but asymptomatic. So that's why we remain challenged with the EP study, and that's why the boards should not ask about an EP study. There may be a role for quinidine. This is probably the only place for quinidine left, and that is Brugada syndrome and symptomatic Brugada patients or patients who are having recurrent ICD shocks. There's a role for RV outflow tract epicardial ablation in the Brugada patient who's having recurrent shocks. And remember, for all Brugada patients, fever is an important thing to counsel about and to reduce with antipyretics. There's some drugs for Brugada syndrome that they should not take because it may precipitate or trigger or unmask a Brugada event. And this is a very helpful website for your patients. And you're also a bit of a killjoy to your Brugada patients because you'll instruct them no alcohol to intoxication, no cocaine, and no marijuana. Those are all Brugada dangerous. So remember to tell them that. Well, let's do the same learning objective now for the disease catecholaminergic polymorphic ventricular tachycardia. And your patient exhibits this ECG during stress testing. And during the stress testing, he's 23 years old. He comes to you because he just had a near drowning. And on the treadmill, he gave you that ECG of exercise-induced bidirectional VT. Your diagnosis is clear and convincing in your mind, has symptomatic CPVT. ICD monotherapy is indicated or recommended, and let's not even worry about the automatic way. Who would give him an ICD as his treatment program as monotherapy? No. Who would not? The knots have it, and that's really, really good because unlike symptomatic Brugada syndrome, where we absolutely would do an ICD by itself, nothing else, symptomatic CPVT, we might do a defibrillator, but never by itself. Never as monotherapy. So let's look at CPVT, where clinically its storyline is a structurally normal heart with exercise-triggered seizures, faints, sudden cardiac arrest, and you feel like it's long QT syndrome, but the only reason it mimics long QT syndrome is we're probably more aware of long QT than we are CPVT. But then you do the 12-lead ECG and you say, where's the beef? Where's the QT prolongation? And when there is none, and the QT is normal, immediately think that you're dealing with CPVT. Do the treadmill stress test, and then if you get the board's question answered, bidirectional VT, you're there. But for our patients, don't wait for fulfillment of the boards, because the vast majority of CPVT patients, the vast majority, will not do this on stress testing. They won't give you the whole enchilada. Instead, become suspicious in the right story, in the right setting, when they start giving us PVCs at heart rates of around 120. Then as the stress test continues, it might escalate, the it being the ectopy, and it might go from single PVCs to PVCs in bigeminy to then PVCs as couplets. You might even see a bidirectional couplet, and then that will be it. It may disappear at the highest work phase, but if it still is there at maximum stress testing, the ectopy will disappear in the recovery phase. That's CPVT. So that will be far more sensitive for CPVT, whereas bidirectional VT is really specific for CPVT genetically or one other entity pharmacologically. Anybody? Digoxin, exactly. And whether it's digoxin or pathogenetic CPVT, we're dealing with a problem in calcium-induced calcium release. And for CPVT, it's due to perturbations about 2/3 of the times in the ryanodine receptor, the gene RYR2 that encodes the ryanodine receptor that contains almost 5,000 amino acids. So for CPVT, genetically we're dealing with leaky ryanodine receptors that cause excess calcium in diastole, mimicking pharmacologic digoxin toxicity and predisposing to arrhythmias through delayed after depolarizations that you heard during the previous lecture. Now, ICD therapy, when do we do that in CPVT? We do that, but never alone, in aborted cardiac arrest, when they're not liking or breaking through their beta blocker or their combination drug therapy. We used to do that when they presented to us as symptomatic CPVT, and we used to do that when we caught them in an asymptomatic genotype positive state. You heard used to. Now the only clear indication for an ICD as part of the CPVT patient's program is the aborted cardiac arrest. Why are we using the ICD so much less? Is because the ICD has been directly responsible for the deaths of several CPVT patients, with the inciting shock being an inappropriate shock secondary to sinus tachycardia that woke up the Kraken. And then all heck broke loose with the electrical storm that the device could not restore order. So we try very hard in this disease to not use an ICD, and we never use an ICD by itself. Instead, emerging role is flecainide, combination drug therapy with beta blocker, preferably Nadolol, and flecainide works really well. And sometimes we will do combination therapy or triple therapy with the inclusion of left cardiac sympathetic denervation surgery. Now let's finish our time because there are more questions on the boards about long QT syndrome than any of the channelopathies. So let's apply these learning objectives to long QT syndrome. And you're going to help me with her, this patient who has this ECG. She's 35. She fainted while running on the treadmill in your stress test laboratory, and you subsequently diagnosed her as having long QT syndrome. And even before the genetic test came back, you predicted LQT1 status, and you were right. And her QTc at rest is 503. You'll recommend an ICD. Who will recommend an ICD as part of her therapy? A couple. Who will not? Great. Well, by the end, you're going to be confident in a no answer. So here, in contrast to symptomatic Brugada syndrome, of course an ICD. Symptomatic CPVT may be an ICD, but never alone. Symptomatic long QT1, where her event occurred in an untreated and undiagnosed state, we can be absolutely confident in a non-ICD treatment strategy to start with. And why will that be for this syndrome? We know a lot more about this syndrome now. We're celebrating its 60th anniversary since its sentinel description. We now are the birth of this entire discipline of the cardiac channelopathies. This is a 22-year-old field now, that of the cardiac channelopathies. We've moved from the era of research-based genetic testing to clinically indicated genetic testing has now been in place for the channelopathies and the cardiomyopathies for over 13 years. Quite a long time when you think that our genetic IQ about these disorders is still lagging quite a ways behind. And then you saw us refer to the latest treatment and guideline document from 2013. So in long QT syndrome, the hallmark is resting QT prolongation, which, as we'll talk about, they may or may not show. When they have it, they're more likely to have a long QT triggered event of long QT triggered fainting, seizing, or ceasing, and that's because their heart went into the long QT trademark arrhythmia of torsade de pointe. Now, when we evaluate patients, the story is the most important because you and I, when we're eliciting the story of the faint or the generalized seizure, we're having to picture what the rhythm was. Are we envisioning when we hear this story about this woman who is nursing postpartum and the phone rings that she collapses and faints? Are we picturing torsades as the basis for the faint, or are we picturing a normal sinus rhythm vasovagal mechanism? And what you and I are concluding then directs what we do and how aggressively we treat that patient, because except for death or aborted death, the strongest predictor of a future faint or a future funeral is an LQT-triggered faint. So the faint that you did not like the sounds of is our sudden death warning sign. That means we better ratchet up and intensify therapy. That does not mean go straight to a defibrillator, but that is the high-risk feature. And some kind of faints we should view as penalty box faints until proven otherwise, and those include, besides the phone ringing, the sudden exertion-triggered faint, fainting in the postpartum period, or generalized seizures. How much work do we still have to do to convince our neurology colleagues that a full generalized seizure, especially during exertion or in an auditory stimulus, deserves at least consideration of the organ south of the brain and a 12-lead electrocardiogram, which we still don't do very well. So when we're suspicious about the story, then we commence with the evaluation, and the most important diagnostic test is the ECG, where we're looking for perturbation in cardiac repolarization. And our challenge with that is we may not be so hot, that is us, the community of cardiologists, in independently vetting and confirming the computer QTC's accuracy. And we are challenged by at least a third of heart rhythm specialists and 3/4 of cardiologists to determine what is the QTC truth. And so we'll go back to some basics. When you and I confirm the computer's QTC, we need to look at the QT and determine the QT. And I think one of the easiest things to do from a practical standpoint is to do the avoid the tail, teach the tangent, take the end of the T wave there, do not censor it at the end of the U wave and commit the sin of U wave QT inflation from U wave inclusion. And that is the number one reason for overdiagnosed long QT syndrome in our program. But then you have to decide, besides the length of repolarization, what you think about the look of repolarization. So here's the length of repolarization. Let's say you agree that the QTC is 475 milliseconds. Are you bothered by this value? Is it actionable? We'll have the look of repolarization to deal with as well, and that was one of your pretest questions where Dr. Amon said you 93% got this one right. So why did you get that one right? Because not all looks of repolarization are normal, and some look abnormal. In fact, some look like a defect in the casein H2 encoded Kv11.1 potassium channel, otherwise known as LQT2, which you were all right. And that is the hump, bumped, and notched looking T waves out there in the lateral precordial lead of V4. Boards love this. Broad-based T waves, think LQT1, humped, bumped, notched, think LQT2, and a normal-looking T wave inscribed after a long isoelectric segment, think LQT3. So with that primer, you would say this is really easy. For the boards, this is LQT3. Perfect. And it would be for the boards, it's just not for this patient. So while it's right for the boards, just remember that the patients don't feel obligated to necessarily follow the papers that we write about their disease. So the genotype-phenotype correlations are useful for the boards, but need to be confirmed in the reality of the practice. What about this ECG? Here's the QTC. Here's the length of repolarization. Does that bother you? Does that length bother you? No, not at all. You see the look of repolarization really looks normal, and your ECG diagnosis is L-normal in somebody who absolutely has type 1 long QT syndrome. So what's important here is that the only way we can exclude the diagnosis of long QT syndrome in a family with the established diagnosis of long QT syndrome is a family-specific negative genetic test. We must stop telling family members your ECG is normal, therefore you don't have long QT syndrome. They may have a low-risk version of long QT syndrome, and almost certainly they do, but that low-risk version could be suddenly dead in the setting of Zithromax or levofloxacin or any of a number of QT aggravating drugs or medical conditions. Let's come back to that length of repolarization. You now know the looks for the boards, but what's length of the QTC is too long? When would you move on it or do something more? And I'm just going to, you can have your number in your mind. We won't profile it with a question. But here, if we did, we would get a beautiful Gaussian distribution of our answers. as to when we would choose to act on this metric of cardiac repolarization, where the surface 12-lead ECG-derived QTC represents the health of myocardial repolarization. You can see it in health and you can see it in long QT syndrome, where the average in our program's 480, and outliers, really long, not a diagnostic dilemma here. For risk stratification, we once said 600 milliseconds, and yeah, that is a high risk feature, but that's kind of like a myocardial wall thickness of 50 millimeters in HCM. You're high risk, but you'll seldom encounter it. So then it got shifted over to 550, but the line in the sand to never forget in your practice or for boards is 500 milliseconds. Because no matter why our patients cross 500 milliseconds, except for two reasons, minus two reasons, anybody know what those reasons are? Going above 500 milliseconds, you've entered pro-arrhythmic territory. Your risk of torsades is now higher than it was when you were below 500. Those two reasons are amiodarone, because they always go above 500 and it almost never is pro-arrhythmic, and a wide QRS. If you're above 500 because you've got 50, 60, 100 extra milliseconds because of the wide QRS, then those are not pro-arrhythmic reasons. Any other reason, diabetes above 500, higher risk. Coronary disease above 500, higher risk. Subarachnoid hemorrhage above 500, higher risk. On antidepressants and antipsychotics above 500, higher risk. Genetic mistakes, higher risk. So respect the 500 millisecond line. Now, from a diagnostic standpoint, we are vexed by this issue of being aware that there's a growing subset of so-called normal QT interval long QT syndrome. Almost always the relatives, seldom the probands, but they can be normal. And how normal can they be? They can be this normal at rest. And yet they are a non-zero risk host. But we have to juxtapose that to the 440 line. What is 440 called in electrocardiography? Borderline. A useless term, because what happens with that is borderline QT prolongation gets quickly translated into what? Possible long QT syndrome. And if you made that Rosetta Stone translation, you now have done a huge disservice to yourself and to the families. But we've scrapped the borderline because the guidelines have replaced borderline with a guideline-sanctioned ECG definition of prolonged QTC at 450 or greater for men or 460 or greater for women as the ECG definition of a prolonged QTC. Keep in mind, this is for boards, ECG definition of prolonged QTC, but our patients who satisfy this ECG definition of prolonged QTC basically never have long QT syndrome. Well, they do, just less than a 1% chance. So satisfying the guideline definition of ECG designated prolonged QTC by itself almost never equals I caught long QT syndrome. So in practice, remember the 500 millisecond, not only for risk, but also for I think I might have stumbled into long QT syndrome. If you cannot explain away 500 milliseconds on low potassium, low whatever, drug X, Y, and Z, we have stumbled into the patient who more likely than not has this 1 in 2,000 disorder called long QT syndrome. Caution lines that I think deserve asking some questions are 480 or above in women, 470 or above in men, and 460 above before puberty represent I should look into this lines. In an asymptomatic host, their pretest probability of long QT syndrome, when there's no other reasons for being out at the 99th percentile value, is about a 10% chance of stumbling into this 1 in 2,000 potentially lethal, highly treatable condition. Well, let's look and turn at the genetics of long QT syndrome. We did Brugada syndrome. That's now easy. Your answer, loss of function sodium channel mutations, but not right very often. We did CPVT, 2/3 leaky ryanodine receptors. And now in long QT syndrome, the vast majority, 2/3 of all long QT syndrome, are due to loss of function mutations in one of two voltage-gated potassium channels, like the voltage-gated potassium channel shown here. There are a lot of long QT genes, not quite 23 like Brugada, but there are now 17. You don't have to know 17. You need to know for the boards 3 of them. The big 3 long QT genetic subtypes make up the questions that would be genetically relevant to long QT syndrome. A quick reminder of the yield. Brugada syndrome, we're in this territory where most of Brugada syndrome is still not genetically accounted for. CPVT, almost 2/3 just in the ryanodine receptor. Long QT syndrome, 75 to 80% is genetically accounted for, with almost all of that 75 to 80% being one of 2 potassium channels, and the mechanism is loss of function in those voltage-gated potassium channels. The guidelines are quite clear across all of the cardiac societies for the indication of genetic testing for the genetic arrhythmia syndromes, but the impact isn't the same across all of these. So we haven't even talked about short QT syndrome because who cares? It's not going to be on the boards, and it's almost never going to be in your practice. Whereas the impact across the triad of medicine is greatest for long QT syndrome. And I want to just dance through the indications here and then the board relevant questions on genotype, phenotype. Guidelines are pretty clear. If you and I think that the long QT syndrome is the correct diagnosis for our patient, genetic testing is a class 1 recommendation. If we think it, we're going to diagnose them as having long QT syndrome, genetic testing is a class 1 indication. Now the key genotype, phenotype considerations. LQT1, the most common. Loss of function voltage-gated potassium channel disorder to the IKS potassium channel. About 1/3 of all long QT families are LQT1. LQT2 conveniently is second most common. Loss of function to the voltage-gated potassium channel, IKR. About 25 to 30% of all families are LQT2. LQT3 conveniently is the third most common, and this shifts over to leaky sodium channels, or a gain of function in the sodium channel, in other words, the opposite of Brugada syndrome and sodium channel loss of function, and about 5 to 10% of all families are LQT3. The minor genes, they're minor, so who cares? Then the next key genotype phenotype for the boards to review is the gene suggestive ECG pattern. Broad-based T waves, think LQT1. Notched T waves, LQT2. Normal T wave after a long isoelectric segment, think 3. The triggers, sports, activities, aerobics, swimming, think 1. Doorbells, alarm clocks, auditory cues, think LQT2 for the boards. Women in the postpartum period are at increased risk for long QT triggered events, but that's almost exclusively LQT2 women. And then non-activity for LQT3. And then last, gene-specific responses to beta blocker therapy. Beta blockers work absolutely the best in LQT1, next in LQT2, and they work, but they're not as effective in LQT3. So for beta blocker therapy, would strongly urge in your practices use of the non-selective beta blockers of nadolol and propranolol. There's been no randomized study to prove their superiority over the beta-1 selective beta blockers, but we would urge caution with using them. Don't use them. You will not find a long QT specialty center in the world that likes the beta-selective beta blockers. Use the non-selective beta blockers. When dealing with LQT3, the sodium channel version, we tend to use propranolol and then a direct late sodium current blocker like mexiletine. We have other options besides beta blockers. We have the ICD. Before coming to the ICD, just like the preventative measures for Brugada syndrome, there's a lot more QT aggravating medications than there are Brugada aggravating medicines. Remember this list. This website can be very helpful for you and your patients. Now the ICD, great device, almost never needed in long QT patients. So most patients with long QT syndrome do not need an ICD. Most of them are going to be beta blocker patients only. Some of them will be denervated. Who gets the ICD in long QT syndrome? Yes, of course, if you do death and you survived it, you get a defibrillator. In the past, if you broke through your beta blocker or you said, I hate beta blocker, then we went to a defibrillator. But now we probably have a better option than that with fewer comorbidities, and that's the denervation surgery. When we predict the future in an asymptomatic host, we seldom need an ICD, but the situations where we will use one in a class 2 indication is a really long QT interval, over 550, and not LQT1. We don't wait for you to get quite that long above 550 if you're an LQT2 woman. What we should not be doing, though, is implant a defibrillator because of the death of a sibling. Now, you heard the other day, right, that the death of a sibling is a canonical risk factor, one of the big 3 risk factors for which disease? HCM. But it is not a personal risk factor, that is, family history, is not a personal risk factor for long QT syndrome. Nor is LQT3 a direct reason for an ICD, so that's fallen off of the reason to choose the ICD. Now, juxtaposed between devices on the right and drugs on the left is left cardiac sympathetic denervation. That involves the removal of the left sympathetic chain, T4, T3, T2, and the lower half of the stellate ganglion on the left side. And when you do that kind of left cardiac denervation, you give and you provide significant antifibrillatory effect. It's not a cure, but the settings where the guidelines support denervation surgery are, my device has shocked me, let's try to do something to make the future shock less likely. That is clear, a history of appropriate VF terminating shocks. And then I don't like my beta blocker, or I just fainted on my beta blocker. Instead of being compelled to go through the ICD, denervation is an appropriate indication of treatment intensification instead of the ICD. Well, we've completed our sojourn through the big 3 channelopathies, and we've gone through those same learning objectives to each of them with a focus on Brugada syndrome, then CPVT, and now long QT syndrome. And let me take you to the home with some practical take-home points besides the board relevant reminders. Remember, for the channelopathies, prevention saves. These websites are very helpful so that we don't take an asymptomatic, low-risk somebody and make them a tragic, dead long QT patient or dead Brugada patient because of an unwarranted drug exposure. Second, tailoring of therapy is not only possible, but it's essential, as most do not need and should not receive an ICD. Third, beta blockers for most, but they may not be equal. Not a fair question for the boards because there is no randomized study, but in your practice, be very cautious. Don't use atenolol or metoprolol for the long QT patient. And then finally, remember denervation therapy for those difficult to control cases. Don't just let their ICD keep firing. Thanks a lot.
Okay, Mike. So before we get to the questions, actually, how are we supposed to measure a QT interval if the QRS is wide?
Yeah, that's a great question. I think the first thing you know from a long QT standpoint, if the QRS is wide, they almost for sure do not have long QT syndrome. So we have looked at over 1,000 patients with long QT syndrome, and they just do not have a wide QRS. But there can be patients with different diseases that are vulnerable to drug-induced QT prolongation, electrolyte-mediated QT prolongation from hypokalemia, where you want to measure what's been the QT prolonging effect of that perturbation. There's a couple easy ways. Hard way is to now memorize JT numbers. People talk about JT intervals and JT norms. I think the easiest way is to decide whether you agree with the computer's QTC. Did the computer measure it right? Then if yes, just do a wide QRS adjustment. And the way you do the wide QRS adjustment is you subtract 100 milliseconds from the computer's QRS. And then you get a wide QRS adjusted QTC. So let's say the bundle branch block or the pace beat or the whatever has brought the QRS to 200 milliseconds. And the QTC by computer, which you agree, is at 550 milliseconds. That patient's adjusted QTC is what? 450 milliseconds. Because you normalize the QTC as if depolarization or the QRS was 100 milliseconds instead of 200 milliseconds. And I think that's way easier than committing to memory a whole set of JT norms when we barely have a good handle on what's the normal distribution of the QT and the QTC.
Okay, excellent. So let's put the first question up, and some of these are the pre-tests and some of these are additional bonus questions brought to you by the Sudden Cardiac Death Genomic Laboratory. So you're going to look at this family pedigree and decide what the inheritance pattern is.
So the plus is who has it, the mutation. So you see their dad has it and three of the four children are positive for it.
All right, so is it X-linked recessive, autosomal dominant, sporadic, or autosomal recessive? So 59% got the right answer.
Great.
So you want to talk them through those choices, Mike?
Yeah, so if you look at there, the key thing to do for the boards is the correct answer will always be autosomal dominant. So virtually every heritable heart disease that we deal with, whether it's Dr. Aumann's hypertrophic cardiomyopathy or the aortopathies and Marfan syndrome or the channelopathies, we're dealing with autosomal dominant. So again, the key principle of autosomal dominant is it doesn't skip generations. So it's present in dad, it's present in 3 of the 4 children, and we'll have another question talking about the likelihood of it being transmitted to the offspring. So I won't give that part away just yet. You notice that grandma and grandpa were both negative? So that means that it probably what? Started in the father as a sporadic de novo mutation, assuming one thing is correct, right? Yeah. Grandpa's grandpa. We won't have too much lunch conversation on that one, but we'll just assume that that's correct.
The politically correct term is misattributed paternity.
Yeah, and you know what? To be really correct, we've got to throw in misattributed maternity. It turns out that moms are not always the mom anymore. So just to be whole, are both parents the correct source of sperm and egg?
So. All right. So the most commonly identified genotype for this syndrome is which? Gain of function calcium, loss of function sodium, defective sodium, calcium, and potassium, or loss of function potassium?
Who?
I knew it. I knew they would get it right.
I think we've nailed that one. It is interesting, isn't it, that despite 20 years of searching for the genetic cause of Brugada syndrome, we still have the majority of Brugada syndrome unaccounted for, which is finally making people conclude what I have thought has been obvious, that what? Maybe most of Brugada syndrome is not genetic, and at least not monogenetic. So stay tuned on on that one. We may be discovering that much of Brugada syndrome is a congenital heart defect of a problem in the right ventricular outflow tract.
So just out of curiosity, do you extend that same kind of thinking to hypertrophic cardiomyopathy, where there is such a significant portion of people that have clearly phenotypic HCM and no panel positive mutations identified?
Right, and I think that's going to be true. I mean, you know, for the patients that you have in HCM, when they have a 25 millimeter wall thickness and they're under 20 at diagnosis and there's family history of disease and death and the heart is shaped with that reverse curve, well, 80% of those patients have a positive panel. But if you're 68 and you have a wall thickness of 19 millimeters and no disease and death, and you have that sigmoidal look, the yield of the test is about 5%. So I think that version of HCM we're going to learn for sure is probably not even not monogenetic, probably won't be polygenetic, and may have to do with just the angulation of their septum and things like that. So being willing to embrace that not all things are genetic is a good thing.
It's tough for some of you geneticists, though, isn't it?
Not me.
Okay, good. Excellent.
I just look for the truth.
Okay, excellent, excellent. All right, next question. Pharmacologic agents and maneuvers used to treat this syndrome include which of the following? Quinidine, osmoline, procainamide, hyperthermia.
Is 95% the celebratory level?
It is, yep.
Great, I'm pretty confident in this one from you guys.
Ooh.
Duh. Good job. Quinidine, isn't that something? Why do we use quinidine to treat this disease when isn't quinidine a sodium channel blocker? And we use drugs like procainamide, osmoline, and flecainide, which are sodium channel blockers, to bring out the Brugada syndrome. And those are true statements. The reason is that quinidine is a really non-selective sodium channel blocker, and it has a virtue that the sodium channel blockers don't have. It also is an ITO channel blocker, and that restores the balance in the initial depolarization. So the best Brugada drug, presumably, would be a much purer selective ITO blocker, which is called, we don't have that drug yet. And so that's why we use quinidine in the treatment of Brugada syndrome, even though it's a sodium channel blocker. It's the what else it is that enables it to be used therapeutically. And remember, we try to avoid fever and reduce fever, so hyperthermia is another potential Brugada agitator.
Well, isn't it interesting? We've talked about use for quinidine. We talked about using aspirin as an anti-inflammatory drug. We've talked about using disopyramide, and we talked about using colchicine. So old drugs still have value in our current era, despite all the R&D that's going into new drugs, like the ITO selective agent you haven't found yet.
Right.
Yeah. All right, the next question. Your patient is a 40-year-old male with a history of fainting spells and this spontaneous ECG. First-line therapy for this individual is quinidine, pacemaker, ICD, or beta blocker. Yeah, talk us through this one, Mike.
Great. So again, if and since we didn't give the option, decide what kind of faint it was, then you are compelled to have to treat. So this means you concluded it was a rhythmic syncope. When you conclude it's a rhythmic syncope, it's a class 2A indication for an ICD. And that's because we do not yet have enough confidence that the only non-device approach, quinidine, is good enough. There's a trial going on in Israel for asymptomatic patients or even syncopal patients with Brugada syndrome to start with quinidine instead of the ICD. But until we know that answer, the ICD is the only therapeutic choice to start with for symptomatic Brugada syndrome.
Okay. Next question is, this ECG is most indicative of which of the following? increased IK1 current, tight ryanodine receptors, DIG toxicity, or decreased sodium current? Okay, so go over the rhythm and then go through each one of those categories, what that refers to for them again.
So that rhythm strip is the rhythm strip, let's say, on a stress test, or potentially not on a stress test, what if it was just ambulatory monitoring. But the key feature there is see the bidirectional VT before it then degenerates into polymorphic VT and then VF. So there's two things that can be, right? Genetically, that's CPVT, and the pathogenetic basis for the majority of CPVT are leaky ryanodine receptors. So the tight is the gotcha moment there. So the mutations in the ryanodine receptors render those receptors leaky such that they leak the SR content of calcium out into the cytosol, causing diastolic calcium overload. So that's the correct answer, if the answer was leaky ryanodine receptors. But the mimicker of leaky ryanodine receptors is digoxin toxicity, which pharmacologically causes diastolic calcium overload through a completely different mechanism, remember? The sodium-potassium ATPase thing that causes the reversal of the sodium-calcium exchanger, that causes calcium entry through the sodium-calcium exchanger and causes diastolic calcium overload through that mechanism. The other two choices are just the teasers. Choice one, increased IK1 current, that's short QT syndrome, so that's who cares. And decreased sodium current, you already told me that that's Brugada syndrome, or at least the most common genetic subtype of Brugada syndrome.
Excellent. All right, so the next question. Your patient has this disease and is pregnant. What is the likelihood that her fetus will be affected by the disease, assuming it's the mom? 25, 50, 75, or you don't know?
Good one.
I was listening.
Yeah.
Mm-hmm.
So this is really good. We went from 48% pre-test to even more wrong post-test at the 61%. But I kind of wanted you to do this because this is the key thing in the genetics video. And if there was one point from the genetic video for us to emphasize, it's this point here. We already said for the boards, a cardiomyopathy, a channelopathy, and aortopathy, you're going to always say autosomal dominant, with few exceptions. Then when we say autosomal dominant, we have to understand transmission risk and expression of disease risk. So this seems like a little tricky, but it's meant to be intentional. The operative word were the likelihood that the fetus would be affected by the disease. You'll see in the next question, that's a different statement than what's the likelihood that the fetus would inherit the mother's disease-causing mutation. That way is autosomal dominant transmission risk, 50-50 flip a coin. In order for the correct answer to be 50 on affected, what would we have to know about our diseases in cardiology? That the penetrance is 100%, meaning possession of the mutation will guarantee expression of the disease sequelae at some point in time. And that's just not true of essentially any of our diseases. And this is what's so critical in our counseling for families with HCM or familial DCM or CPVT or Marfan, is that inheritance of the mutation, yes, 50-50, but expression of the disease until we know a whole lot more than we know right now is actually uncertain, unknown, and time will tell. So there's good news in that messaging for these families is that even though they may inherit the mutation, they may never show the sequelae of the disease. And that's why we see in long QT patients, the most at-risk person is the proband. And then there's all of these relatives who own the mutation, and yet most of them have a completely normal QT interval. And we see in your practice, the HCMers, the proband has it, but there's many other mutation-positive family members, and every test that he does every year or every 3 years or every whatever surveillance, including the MRI and DHE, is still negative. And it will likely stay negative for the rest of that person's life. And so I think it's really exciting for us in the future to figure out how do we predict the penetrance assigned to the patient and the family's mutation that they've inherited.
Yeah, that's a good point. So the most likelihood is 50%. The chance that the child will be effective is much less than 50% for this woman.
In that scenario.
Yep. All right, so the next question, he kind of gave you the answer during that discussion, so let's see how much we were paying attention. Your patient has this disease. What is the likelihood that her fetus will inherit the disease susceptibility mutation?
Let's just nail this with 100% unless anybody wants to just play with us up here. Okay, just play.
That 4% was probably the Mayo fellows that
Yeah. I know
that are
who
messing
you are.
that are messing with you. Yeah. All right. So that's the 50-50. So the next one is congenital long QT syndrome is most often caused by defects in which of the following: voltage-gated sodium, potassium, calcium, or non-ion channel membrane proteins. Not bad.
Great. Really good. So we know that 2/3 of all long QT syndrome is loss of function in one of two voltage-gated potassium channels. LQT1 is a voltage-gated potassium channel that's compromised. LQT2 is the other voltage-gated potassium channel that's compromised. And those two alone are responsible for about 65 to 70% of all long QT syndrome. Sodium channel is 5 to 10%. The other 14 long QT genes is about another 2 or 3%, and about 20% of long QT patients who clearly have the disease will have a negative genetic test in 2017.
All right, got a couple more here. The next one is, looking at that ECG, the LQT genotype is going to be which? 1, 2, 3, 7, or don't know?
And if that ECG doesn't show you what you deserve to see, is
there
that.
You go.
So it would have gone from 78 to 100% because the notched T-wave look is the pattern recognition for LQT2. The broad-based T-wave is LQT1. And the normal looking T wave inscribed after a long isoelectric segment is LQT3.
All right. Last one is a patient is a 16-year-old male. He has a history of near drowning. The most likely explanation is the sodium channel mutation, potassium channel IKS channel receptor loss of function, the IKR loss of function mutation, or the ryanodine receptor mutation.
I just wanted to give you one question for the genetic cardiology boards. So that's what this one is. Would be on the genetic cardiology boards. There's not that subspecialty yet, but. So this is one where the ECG, if you had a bet on the ECG, is LQT3. But the story is a story of LQT1. And the story always trumps the ECG profile. So once you said to yourself, I'm dealing with LQT1, then you needed to see which of those options are an LQT1 pathogenic explanation. So number one, loss of function in the sodium channel, well, that's really straightforward now, isn't it? That's Brugada syndrome. So that's not even long QT. Number 3, loss of function to the KCNH2 encoded IKR, that's LQT2. That's the doorbell alarm clock postpartum hump bump notch T-wave looking version. And then the gain of function mutation in the ryanodine receptor, that is not really any clear disease yet, because ryanodine receptor mutations are leaky, and one could argue, is leaky ryanodine receptor, is that a gain anyway? But that's CPVT, and that ECG, is that a CPVT ECG when the QT interval is really, really long? No. So your answer for the 48% who nailed it, loss of function mutation in KCNQ1, which encodes IKS, which is the LQT1 associated potassium channel. So that was for all the marbles and for the future genetic cardiology boards.
Yeah, so just to summarize though, I think the most likely thing you're going to see on a board examination is being presented with a patient with a long QT syndrome and trying to make the decision about whether a defibrillator or beta blocker is the next therapy. So do you want to kind of just give a quick thumbnail of what traps not to fall into?
Yeah, so for the boards, the guidelines I would resort to, the guidelines currently call for universal beta blocker therapy, regardless of the QTC and the asymptomatic host. So when the QTC is above 470 at rest, it's a class 1 recommendation. When it's below 470, it shifts to a class 2. But basically, an encouragement for universal beta blocker therapy. On the other end, for going to a defibrillator, we go to a defibrillator in the setting of aborted cardiac arrest, and we go to a defibrillator in the setting for the need to intensify treatment. And the guidelines will support equivalence in your strategy to intensify between changing the medicines, adding denervation, or adding a defibrillator. So the symptomatic long QT patient who hates beta blocker then needs treatment intensification, for which you could do any of those. Pick a different beta blocker, a lateral move. Pick denervation or pick an ICD. What the boards will try to make sure you aren't doing is asymptomatic person with long QT, with a QTC that's kind of a yawner, so under 500, to try to bait you into answering ICD. They want you to say, nope, not ICD. We have plenty of room to just be preventative medicine, pharmacologic medicine, prevent QT drugs, and be on a beta blocker.